thanks for coming. This is an off-cycle course seminar, but we're really enthusiastic to support it. We have Dr. Alan Forster, who is the Director of Quality Improvement and Performance at the MUHC, who's doing, I think, some very cool things with data and trying to tackle a super important problem that I think most of you are familiar with, or you've set foot in the hospital. So I'll hand it over to you to tell us what it's about.
Thank you. Thanks, Ben, and thanks everyone for coming, and thanks for the pizza. I don't know I think that's the core program, so I think that's a great draw for people. Probably more important draw than the speaker, but no, it's a great pleasure to be here because we're trying to promote a more scientific approach to management at the MUHC, and it's going to take scientists to help us do that. So to come here and be part of this group is a nice honor for me. And this is a campaign we're focused on. There's so many priorities in healthcare that sometimes it's very easy to get lost. And so one of the things we're noticing at the MUHC is that our length of stay in the hospital is longer than everybody else's in the network. And obviously people say that's because our patients are sicker, but when we compare ourselves to other institutions in Quebec who are similar in terms of their role, we have a longer length of stay. And that's a bit of a problem. I'll get into that. But the idea is if we can focus in on one thing at the MUHC this year, and I'll get into why we've chosen this, it'll help us get a bit further forward. And because if we all focus on the same problem, then we'll learn more about what it takes to solve problems and so for us, this solving the stay or addressing this length of stay issue is about improving access to care. And access to care, how does like a prolonged hospital length of stay cause a problem with access to care? It's really kind of through two mechanisms. One is, people, if the hospital length of stay is too long, that means new patients can't come into the hospital. And patients come into the hospital really in two ways. One is through the emergency department because they have an acute illness, and the other is through surgical day care, same day admits through the surgical day care program. So it's either through an emergency or a planned admission. But the more people we have in beds, the less people we have less open beds we have, the less people we can bring in from both of those routes. And we've done some back of the envelope calculations. If we have if our length of stay on average is a half day longer on average, that's like over the 33,000 encounters we have. That's a substantial number of beds, and that would translate to a significant opportunity for patients on a day-to-day basis. So there is an access to care issue here with our length of stay being long. But here's where I feel that there's a nice alignment. It's really around with the research community, because how do we understand whether someone's staying in the hospital too long, or maybe where are the opportunities to reduce the hospital length of stay? It comes from understanding the underlying illness of the patient. It comes to understanding some of the other demographic or social conditions that the patient's faced with. It also is influenced by some of the care delivery decisions that get made, which can be understood through analysis of variance. All of that can be understood through analysis of variance. And so to set up questions that use data that's captured in the routine aspect of care, we can actually ask questions that we could produce generalizable knowledge about the patterns that we're seeing in Montreal, but also that could apply elsewhere. So there are definitely opportunities by looking at the length of stay to come up with some theories about what's driving health utilization. And so we've launched this Solve the Stay campaign, and the Solve the Stay campaign has two. This is at a hospital leadership level. Dr. O'Patterney has put on her strategy that she's going to reduce hospital length of stay. That's her goal. And so our current is about 8.5, although I just saw the last data, we're creeping up even higher than 8.5. And the average in the net, like the average of the teaching hospitals in network is below 8. So we said, okay, let's try and get down to below 8 as this goal for the calendar year or the fiscal year. Sorry. And we see that there's a kind of a opportunity here to foster grassroots engagement and to go through a process of analysis, understanding the problem, and then developing solutions, and then proposing those solutions, and then having those solutions being put in place, and then evaluating. And you know, we at the bottom you can see we've got an idea where we're doing a sort of broad-based approach of getting people engaged to do these analyses. And there is also what I'll call a top-down approach, where we're coming in kind of with a hypothesis already as to two areas for improvement, rather than like from the grassroots, which I think ultimately will be more impactful because there's more people and ideas are closer to where the action is. But that will take time for it to occur, and there will be a process because we want to get moving on certain things. We're moving on a couple of areas. And those two areas are the patients admitted for emergency surgery who end up having to wait often for an OR. And so they sit in emerge, or they sit up in a bed upstairs waiting for surgery, and sometimes up to like many days, even up to a week or two. Oftentimes that's because they have an illness that requires a wait, or some kind of, but many times it's because there's just no OR available for a variety of reasons. And so that's one area where we need to tackle. And then the other is towards the end of life, when people are admitted, we see people who have care that is persisting beyond a period of time where many people would say that is producing benefit to the patient, and often is associated with sort of increasing pain, increasing isolation from loved ones, etc. So the idea is that there's two areas where we're driving quality improvement. We'll get into that a little bit, but there's already analyses demonstrating where the problem is, and there's teams engaged in addressing those problems. And so the idea is that overall, by having these two approaches, and again, we want to use MDClone as the data source because it allows us to do this broad-based approach well, and I'll get into MDClone a little bit because I'm not sure if everyone knows about MDClone. But the idea is it really helps democratize access to data. So the idea is that we can help give people access to these tools to then support this grassroots change that we're aiming for. And so part of this is to also not just to drive the specific goal of reducing length of stay, it's also to help people learn how to use the data tool that we've brought in, help people also understand how to move from an analysis that shows some kind of conclusion to a decision to change, and then like application of that change, not at a micro level, but at a more like at scale, like where lots of ideas are coming forward to solve a problem, and how we move it forward. At the center of this is our thinking is that we're trying to create a learning health system, which is really around systematically gathering and creating evidence from care, and combining that with research methodologies that help us turn that data into evidence that's meaningful and generalized. And I think people here have probably heard that discussed, but this is more, we really want to get into a very practical application of it. And maybe what I'll just say is that for us, and where we've seen great input in other centers, is where faculty have junior trainees, junior staff, or trainees who can participate in this work, and are actually often the ones who do make the big improvements. So what I would just say is it's kind of nicely, this platform is nicely attuned to that group of people because the MDClone platform doesn't require a grant or money to pull the data together. It's there available to people. And so really the main obstacles to using it are time and time and learning how to use it. And the learning, we can help give training to learn how to do it. So if you have folks who have time, it is a great benefit. And I'll just say that we do anticipate and we're going to promote the achievement of academic goals through this, whether it be through publications or using the results of our analysis as a platform for future grants. I'm going to talk a little bit about MDClone as to why we're using MDClone as the source of this. Can I just ask people if people have heard about MDClone here? Okay, so about a third. So as you know, we've had a great data warehouse at the MUHC for years. The data warehouse is managed by a team of people. If people want access to data in the data warehouse, traditionally they've had to go through that group of people. There's a variety of reasons why that sort of architecture is required. The MDClone, the reason why is because the privacy approaches require us to have a specific purpose for each use of the data, and therefore the teams, most people can't access it because they're using it for a variety of purposes. And so I don't want to get into the privacy approach, but just to say that there is that sort of bottleneck right now of people who are in a way enabling access, but there's just too few of them compared to the demand out there. And so we went forward with MDClone to help us overcome that because it allows people, and we've loaded, I'll get into what we've loaded into MDClone, but there is data in MDClone now that reflects much of what's in the data warehouse. It's been translated into the MDClone format. So now you can essentially access the data warehouse data yourself without having to go through that central group. And then what makes that possible is this concept of synthetic data. Synthetic data is it's artificially created data, it's artificially created from the real data. So if you had this is just a symbol, but a group of people with characteristics, the synthetic data generator creates what looks to be real patients, but they're made up. It's completely fake. It does that through a variety of means, but ultimately the statistical characteristics of the synthetic data match the statistical characteristics of the real data, which allows you to do analyses which are useful for hypothesis generation and for feasibility assessments. We have set this up so that you do not need, because the synthetic data, because it's impossible to go back to an individual patient, it's not considered, it would be considered under the laws not requiring IRB approval for disclosure. So that means people can get access to the synthetic data without having IRB approval. And that means you can play with the data and do things with the data without having to go through regulatory steps. And second thing is it's also easier to share data beyond that initial analysis. You can, if you want to share across jurisdictions, countries, it's much easier. And because most of the work has been set up, it doesn't require a lot of extra resource and support from the central teams. So basically, the way MDClone works is there's a pooling of data from any source, and for us, we've used the data warehouse as the main source, but that's already pooling data largely from many sources. So, and then it structures data into formats that are readable and usable. just to say that we can go from some of the text documents. We haven't done that yet, but text documents can also be structured into structured unstructured data can be translated into structured data. The MD one of the great things about MDClone is it's set up in a way that an epidemiologist thinks, in that there's you know, inception events, and there's covariates, and then there's outcome events. And so the data is structured in a way that makes it very easy to set up a table for analysis. It doesn't take a lot of extra coding skills to do that. And then the last part of this is around setting up the synthetic data. So, and when you do the work with MDClone, part of what they'll do is teach you how to construct an analytical data set, which then gets translated into a synthetic data set. I think it's really important for folks to recognize that the synthetic data is generated from real data. It's not like we have a pool of synthetic data sitting somewhere that people are then accessing. We have the real data. You design your query based on what you want, and then you get exported the synthetic data. So the real data is there. So once you've done your analysis and determined something of interest, it's quite easy to go back and get the real data. And oftentimes that IRB process, and we haven't had a lot of requests in this chain, but where in other places where they've set up MDClone, they have set up a methodology where you know, they can quickly go to get that approval to get the real data, because the query's already being created. You don't have to, no one else has to create the query. So it's just really about a permission to access. People may question about MDClone for research. There's lots of papers like this comparing synthetic data to real data and the conclusions. This is one that was done in Ottawa with some of our stroke and oncology and thrombosis doctors. And they basically looked at comparing synthetic data to real data and the conclusions that were drawn. And just to show, this was in a population of patients with stroke, and whether or not they had cancer at the time of presentation. And they looked at recurrent stroke and death, and found the same conclusion in cancer. They found the same conclusion with the cancer, with the synthetic data. I mean, as I said, there's lots of papers. I would just say, like, fundamentally, we're not expecting people to publish with synthetic data. I think the point of this is that you can use synthetic data, and the answers you get are going to be very similar to the ones, or exactly the same as the ones you would get with the real data. So if you're working on a proposal or a manuscript or even a conclusion for senior management, you can do work with the synthetic data, come up with your directional information, and then move back to the real data. It's not to replace, it's just to show that it's useful. One thing that's also very important to recognize, there are some limitations of the synthetic data. Like, just to be clear, there's some limitations. If you have small sample sizes, it can be tricky. If you have outliers, it can be tricky. There's ways of handling that when you're working with the synthetic data and you're working with your original data set. But you need to learn those ways of dealing with it, because it's not completely magical that it'll solve all the problems. If you have small sample sizes, there's not enough information to create the synthetic data. And similarly, in scenarios of small cells within a large data set, there may be identifiable information that comes about even when it's synthetic. And so the system itself suppresses small cell size groups. And so as an analyst, as someone who's working with the data set, understanding those limitations and then adjusting your approach are necessary. So we've implemented MDClone. It was a bit of a journey creating it, but just to show what we've done in the last couple of years, and thanks to Mona Malouf, who's here, and others, and Keith Woolrich's team, Uh, they're supporting the data warehouse use and availability. So that they're the team that's really helped support that translation of all the data from the source system into the data warehouse. But now we've taken it the next step into and loaded it up into the MDClone data lake. And just to show what we've moved over, so about 18 years of data, 4.75 unique patients. We have information on the types of entities that we're tracking and when they start appearing in the database. And we also have the periodicity of the refresh. So this is continually being refreshed weekly. So you could almost think about how you would use this from a quality improvement point of view, or even a study recruitment point of view. If you want to see the new patients coming in, you can set up a protocol so that it gets updated weekly in your system. Currently, like I started this talk by talking about the length of stay campaign. We have 31 ideas for length of stay reduction right now coming in. Okay. Now we want to get that over 50 before March 31st. And that's why I'm here today. Because I think if everyone in this room gives one idea, or maybe 10 ideas, or maybe one person gives 20 ideas, we'll be over the 51. Oh, really? Okay, there we go. So maybe just the Zoom people have to do the work. Maybe they should just log into MDClone right now and put in their idea. So just to show you, like I mentioned also at the start that there's top down, and we're focused on those two things about emergency surgery and end of life. Just to show sort of why we're focusing on the end of life, like we looked at so-called end of life conditions, and there's a number of those that have been defined in the literature. If over the period of 2021 to 2024, a third of the hospitalizations had at least one end of life condition documented. Their 1 year mortality is 13, but in hospital in year mortality was 13%. If you didn't have an end of life condition, it was 0.7%. So it doesn't mean you're at the end of life, but it means you're nearing the end of life, I guess. But if you look at the health service utilization of people at the end of life, many people had. You can see that the ICU admission rate. You can see the length of stay compared to the non-end of life, and we know also from other information at the MUHC that there's a significant gap at our institution related to advanced care planning and access to palliative care. And in fact, if we look at interventions that implement systematically an advanced care planning intervention as associated with palliative care, we see significant at like a health system level and at a hospital level, we see significant reductions in hospital length of stay. Now, part of the trouble with this particular project is how you communicate that, because it's yes, there's a reduction in hospital length of stay, but what that actually means is that patients are getting hospitalized in care for things and ultimately dying without getting appropriate palliative care and advanced and supportive care at the end of life. And speaking with people locally, that's a particular problem. So that's why we're trying to put a financial term on this, but there is actually, and what we're hoping is we go through this, there's actually a quality of life, quality of care goal on this as well. It's not really about the length of stay. It's about the quality of life at the end of their life. But there is a financial benefit, which if we look through in this model, which is quite a conservative estimate in terms of if you take the number of people who are dying in the hospital and how long their length of stay is, you translate that back to what would happen through these advanced care planning activities, we'd see a fairly substantive reduction in hospital days and in dollars. And so really what we're doing now, and this is why it's top down, is like we're working, the senior leadership team is working to engage our palliative care team, Justin Sanders and group, to help push through this advanced care planning intervention. He's got funding from the foundation to support it, and we're really that will be happening. And so that now produces a whole bunch of evidence related to advanced care planning intervention. And it's aligned with best practices out there in the world that we're not currently following. Um, Now, we also want to go to the grassroots, and this is why we're here today. Um, and part of the grassroots, and this is why we're focusing on a topic, which is this length of stay topic. It's a very measurable thing in the data, right? But the idea is we can quickly teach people how to use MDClone if we have a common outcome, a common framework. But we also see that there will also be great synergies between the scientific community and the hospital administration community, and the clinicians that work in the hospital, because it'll align people to the same kind of problem. And the idea is that we've created these workshops, and some of the people who teach them are here, Santiago and Marcel, and they're helping us move that forward. And the idea is that we teach skills required to use the MDClone Atoms platform. There's an opportunity to provide protected time for people through that training period. And the intention is to focus in on this analysis of length of stay, with the intention that those analyses will be actionable and lead to potential quality improvement initiatives that we apply at the MUHC. And I guess we have a series of dates set up for these here. We're doing them through this venue here of CORE. And they're basically open to anybody who's here. Like who like it could be your graduate students, it could be your research assistants, could be you, it could be whoever is interested in this and has time. And so it could even be students who you think you're trying to recruit into your program, like maybe they're residents out there and they want to come and do a graduate program later. But the intention is that they get the support from our team to focus in on these issues. Now, I will say that length of stay is an interesting problem because there's a part of it which is the underlying illness of the person and what their care is having to recover. But there's often lots of things that happen to patients that influence length of stay. Like I mentioned, the delay in getting to the OR is one. But there's other delays that happen in the hospital, delays for diagnostic tests, delays for consults. There's also complications that happen in the hospital. So, you know, you could get a hospital-acquired infection. We know that's associated with prolonged hospital stay. You could end up with other hospital-acquired injuries. It doesn't have to be an infection. It could be a medication-related problem. It could be delirium. And it could also be physician choice. So physicians, we often see quite a broad range of length of stay by physician. So it could also be length of the day of the week that someone gets admitted to the hospital. Okay. So if you're admitted to the hospital on a Thursday or a Friday and with an expected length of stay of 2 days, you might end up waiting in the hospital till Monday because things don't happen on the weekend. And so we often see things like length of stay effect or length of a day of week effect on length of stay. And so there's a whole bunch of, and I would just say, like, fundamentally these issues, people know the issues more than us, right? Like the people who work in the hospital, people who work with clinicians, work with patients, they know what the issues are better, or they might have hypotheses about what those are. And the idea is that the data are things they can now justify or investigate it and see if it's something we should spend a lot of time worrying about. And you could actually start to think about translating the cost of some of these things into money, right? Which could then turn into a ROI calculation for the intervention you want to propose, or return on investment. So just going back to how we're moving this forward, we're calling them the skills accelerator sessions, not SAS. Maybe you use SAS after you get your data, but so the first one is the sort of introduction, data overview, by the end of the session, define your reference event. So that's like what gets you into the cohort, your inception. Session 2 is really building the query. That's all the covariates and outcomes that you're interested in. And then the third is doing your analysis in the discovery. Now, some of you will be jumping ahead really quickly because if you're an epidemiologist, this should be very straight, but it's learning how to do it in the application. And there's also a part of this, it's not just learning the application, it's also learning the data. Like you'll see, like there's a guy called John Fletcher. I don't know if you know John, but he knows the data and every system, it's like where it's coming from in the hospital. Like, because all the data that we have in MDClone resided within a data system in the hospital. And so and then that has to get from the data system in the hospital over to MDClone. And so there's transformations that happen. And there's also idiosyncrasies about how the data got in the first place. So yes, you may understand the platform. Yes, you may understand epidemiology, but you also have to understand where the data is coming from and the provenance and the like how it got to where it and what transformations happened. And so like those are things historically that would be kind of trapped in that small group of people who worked with the data warehouse. Now you're going to get exposed to it. And so part of this learning over this time frame is not just the platform, but it's also about the data. And that's something that we all have to learn more about because it's how we improve the system. So we're using Pico as our teaching methodology. So we want people to come up with at least 2 opportunities, but it could be more. What's the record right now, Marcel? Per person? Yeah. Okay. Yeah, but as long as at the end of the day they have to answer 1. Yeah, so if you come up with more questions, you might find like, and this is like, I don't know how many people have used administrative data or clinical data in their research before, but oftentimes you start with a question and you have to refine the question because of the data that become available that are actually available. You might have a science-based question, which is the right question to ask, but it's completely unanswerable with the data that you have available to you. So you have to, there's often a process by which, and the people who do a lot of health services research with clinical and electronic medical record data, they'll have done this so many times, they'll know their data sets extremely well, and they'll know what they can answer and what they can't answer. But when you're starting, and it can be frustrating for people when they start this kind of work because they don't know what's not available. So that's why this process, we recommend using a framework, the PICO framework, which I think everyone here would know. We come up with questions, and again, we're teaching people not just like epidemiologists or clinical research personnel. We're training managers and analysts in the hospital. So that's why we're using this framework to help. It's a standard framework, and so ideally come up with questions, register for the workshop. The deadline, then we do some work in the background to help organize and get ready for it. We have to create some accounts and accesses. We give people some online learning for prep. We give some data literacy training, MDClone overview, synthetic data. And then we want, when that's before February 27th, and then, which is this Friday, right? Sorry, what? What if they're late for that? Is it dead? They're done? Yeah, if they're too late, if they don't. Okay, no, we're just telling. Okay. So look, I think what we're saying is you can be a little bit flexible with this February 27th. Okay, yeah, yeah, and then over the weekend you got to do your questions. Is that it? Is that you get signed up? So okay, so we're putting the pressure on everybody for the timelines. I think we can be a bit flexible with that. And now here's how you can request to access MDClone on the left. And will this work? This will work wherever people are right now. And then the second one is to register for the workshop. So and the idea is on both of those, on the one on the right, you'll get prompted to come up with the questions. Yeah. Okay. Yeah.
Okay. So for the people on Zoom, so the QR code on the right is to register the questions that you want to explore during the workshops. And the idea here is to have as many questions as possible per user so that we can make sure that you have at least one question with the data available to explore during the sessions. And the QR on the left is to register for MDClone access. But yeah, the right is for the workshops. The left is for MDClone access.
So people have to do both.
Yes.
The one on the left by February 27th.
Yeah, that's just an access request. It's like 3 fields you have to fill up: your name, email. Yeah, very simple. The one on the right is for the questions that you want to explore and to register for the workshops.
And one thing I will just say is because of data security and cybersecurity, the people on the left have to have an MUHC email address. It can't be .mcgill. I presume, I'm not sure if or I guess it's the physicians have a government email, so that works. Yeah, so that works. But it's just so that we can quickly ensure that the people are credentialed appropriately. Like we need to respect some rules regarding.
Will it work for RI MUHC email addresses?
Yeah, it should.
Okay.
Yeah.
Okay.
Did you hear that?
If you have MUHC access to the network, then yes.
If you don't have access to MUHC network, we need to make a request, and that's the part that takes some time. And this is why we rushed a little bit.
Okay. All right. So I've gone from very high level, like we want to improve access to the health system, to very practical. Here's the QR code, log in, please. And in between, I shared why we're doing this and some of the data and how we're doing it. I think it's best just to stop now. One last thing I would just like to finish on. We're pushing for this new digital era. We want to have AI assisted work to help transform healthcare. In order for that to happen, we need very sophisticated teams of people who understand the digital world we live in. And you can't understand the digital world you live in unless you can access the data, right? And so this is part of that transformation of the health system. That's where we're going with it. It starts to create a more data and digital literate workforce. This is one day today we're coming with this thing, but there's going to be lots of other things that we're going to work on as we go. And the learning we get from your exposure to this, we will use over and over again, right? So the intention is that this is part of a journey that we're on, and we're happy that you guys are the first step of the journey with us. But hopefully we get somewhere really, really positive together. And we're doing this for the first time with you. If there's other ways to make it better, we'd like to hear. We'd like to hear that. So I'll just wrap up. Ben, I don't know if you would like to say anything or. Yeah.
But overall, I think it's a great initiative where there's a lot of potential. So 2 questions. One is just very technical. So for trainees, it's a tricky thing in many spheres. They often will have a mail.mcgill.ca email address. That's their main identity. Our MUHC employees have an RMUHC identity. So if that sort of ability to have people like that who might be early adopters of this to test hypotheses, overcoming this MUHC address or finding a way to easily give them one would be useful. That's just, I guess, a technical thing. So my question is more, I guess, from a understanding of the data generating mechanism perspective. So does MDClone, I guess, capture, suppose, we have patients who are like frequent flyers. They present to the ER multiple times, 10, 15, sometimes 20 times a year. Is that characteristic captured, or is it really just hospitalization events are independent of other events in the same person?
So I'll answer both questions, but I'll start with the other ones. Like the second one's more interesting than the first question. But the answer is yes, it does. I mean, the way the data are captured, are built in MDClone is around trajectories of patients, and each of these things represent events along the timeline. Okay, and so a person might have many admissions over the hospitalization over their year, or they might have many diagnoses, or they might be prescribed many drugs, and that relationship is what's being built upon.
The follow-up or the related question, very much related to this, and I think important, is does it capture, there's sort of a multi-level nature to the experience of a hospital, and so does it capture if the ER was at 250% capacity that day, it could influence the length of stay for an individual. So there's sort of these, is that sort of multi-level co-occurring stuff captured in the representation of data? And
I'll just start it's captured at patient level events. So I guess you could construct the ED occupancy because you know when they came in and went out, and so you could have instantaneous ED occupancy, but it doesn't calculate, it doesn't have ecological events routinely captured because they're ecological, like, so it doesn't have the temperature outside or whether the understand. But yeah, but you can capture, you can create things out of the entities that are there. Okay. There are other ways in which we can combine data from multiple, like, so if you have other data sets, you can use them for some of these other variables. So for example, if we created maybe a measure of hospital occupancy, because you don't know the number of beds that are in the hospital with MDClone, you don't know the number of staff that are working in the hospital. So we would likely have to bring in other data sets to answer ecological questions. Maybe just going back to the issue of the user, we're on as I said, we're on a bit of a journey. Like we're implementing this, and we have a bit of a complicated environment from a technical point of view. Like we have the RI, the McGill, like, and from a data security, data governance point of view, it's all under the entity of the hospital. So, and also from a software, in the software license, we put it under McGill University Hospital Health Center and RI. So that's included students and staff of those two institutions. So to the extent that your email tells you who you work for, we have to kind of align it back. But part of what we're trying to do is grow. So, and part of this is, I think, a bit of patience on us to figure it out with you. If there's a lot of students, we'll have to figure out how to move it, and we can do it with a small number to get started, right? Like we can do that. It's when we get into a real production system where there's thousands of potential users, and like if you're a McGill student who's working with you, it's not the same as if you're working with someone else in the engineering department, or do you know what I mean? But the email doesn't tell you anything more than that. So yeah. Anyway, yeah.
That was excellent, Alan. Thanks for bringing us up to date on obviously the marriage of MDClone, which started off as using Israeli data just because that's where it started, to actually using data warehouse, McGill data warehouse. That's glorious. I guess when it comes to this, though, I think that the two the issues become the limitations of our data warehouse. I'm not sure if I know it's been continuously expanded. I know that's not directly, it's David or whoever, but it's there's compared to things like Mimic or other databases that medical healthcare, the identified databases that are being used worldwide, our data warehouse has what looks like a lot of lines in that table, but actually, for example, it has all the orders for all imaging, but not the actual images. It has all the notes of all operations, but not the actual operations. and things like that. And it just makes it, I guess, for people to realize that we're limited now, not by MDClone, but by DW.
Or well, actually, we're limited by something before DW. Well, we're limited by what we capture digitally at the point of care.
Right, right.
But like
Yes.
we're kind of limited all the way
Yes.
along, right?
Yes.
And we're also limited in that we don't have what happens when people leave the hospital. Like, so look, as I said it at the finish there, we're on a journey to transforming the health system with the digital tools. Okay. Understanding what we can do today and what information we can tell today is a first step to helping transform, right? And there will be over time an enhancement of what we capture digitally. Almost certainly. We need that to the extent that that tells us about patients and tells us about care, we need to capture it so we can do these analyses. Like, and I would argue what we have right now is an amazing starting point, and we can continue to make it better. And I'll give you some very, very concrete things. Right now, most of our notes are captured by handwritten practices. Okay, if we could go to AI scribes where people are using or if they could simply type it in, or they could use drag and dictate. All of a sudden, that digital information now is captured on diagnoses and procedures and whatever else they want to capture that way. That is now available using LLMs and other tools directly into this. We don't have to go through a whole process of making, but that requires a whole workforce to change.
But we actually, in the hospital, I think that a good 50% or more are no longer handwritten, and they're electronic documents, but I don't think that they're at all in the data warehouse.
Well,
am I wrong? Yeah,
but
there's no narrative, there's no progress notes or notes of any sort in the.
And I will just say, let's do it.
Yeah.
Okay. But look, we're creating a platform now where we can actually start to use those. And MDClone does have a facility in it to help support translation of those unstructured notes into structured data. There are other tools now that are coming out that are just like as created, they become a text document and a coded document, and it's a matter of adopting those. But before we adopt that, and it would not be available to everybody. Now we can move it directly into production, have it in the data warehouse, have it in MDClone. So I agree with what you're saying. We're on a journey. We're on a journey.
I have a question about the availability of sociodemographic data.
Yeah.
Yes. So is, for example, postal code information available? Just because I worry that as we're using a lot of proxies in this type of workflow, we integrate some financial outcomes, which is very reasonable from an operational standpoint, essential. And I really appreciate the fact that it's data-driven management, as you said earlier. It's great. But there's always the risk of algorithmic bias that goes unchecked, right? Not from a malicious, but rather kind of a pervasive, insidious way that's been shown in the literature to exist and to occur. So what are some of the checks that we'll be doing to stratify our analysis to make sure that whatever outcomes the early care for palliative care, for example, doesn't impact a specific group more than it does another? So just in terms of checks and balances, in terms of the algorithmic bias issues that this type of analysis can produce. Do we have any demographic data we can rely on? Perhaps the proxy I mentioned, the postal code, is that available currently on MDClone?
Postal code is, yeah.
So just to answer that about the sociodemographic, for example, sex at birth is there. And also, for example, postal code, the first 3 digits.
Data we collect, right?
Yeah.
Back to your point, but appreciate it. Thank you.
Yeah. The other thing I'll just add is like, is a biased analysis better than no analysis?
No. Yeah, it's worse. Yeah. It's worse.
So, but how do you even know there's an inequity if you have no data or analysis?
The example I have in mind that's very common in the literature is a hospital that wanted to do early interventions with nursing at-home interventions to prevent ED visits to lower costs. What they ended up seeing is that the proxy they used to assess for complex comorbidities was a proxy of dollars. So patients that had more dollars, they assumed were sicker. But that was not the case. Patients that had more dollars could access healthcare more, and ended up, it was in the US, ended up being Black patients who were assumed to be less sick because they had less dollars in their charts, but they were not less
And how
sick
did they find that out in the end?
because they had access to race ethnicity data, which
okay.
That's exactly my point.
But it also
and they were able to actually improve the algorithm. They're able to improve it to actually get better care for everybody.
So I agree 100% with what you're saying. What I would argue is, without having, like, we can't let this risk stop us from moving forward. We have to account for the risk in our conclusions and how we move forward. And that takes people like you and others in this room be aware of what those limitations are and continue to ask questions. That's what I'll say on that.
And that's exactly the spirit of the question. It's good to know that we have some proxies, but there's limitations. It's not by no means a barrier to this being produced.
Perfect.
Without
Just add one thing that we have in Quebec, the Pampalon index.
Of course.
And it's a deprivation index, and it uses the FSA, the three. So, you can add, it's actually more than a proxy. It's been validated as being a good measure. So if you're interested, you can do it with this, with the three, the FSA. Yeah.
Yeah.
But it's
It's available. The FSA is available. Yeah.
just slightly bringing something that's related to something else, and without hogging this microphone, when you talk about marginalized groups and concern about different groups, one of the issues that I found in MDClone, which was quite frustrating but made sense, is that anytime I narrowed my group
it got too small
by one of these things or anything, even something like, for some groups, the moment I click sex at birth, which sounds like a basic thing, it said, sorry, can't do, because it's meant to be that as soon as the sample is too small, it will not do it, because then of course the re-identification is easier. So that's not something you can fix. It's just that, for example, we work at the children's, the numbers are small.
Exactly.
And then I could not get anything done because the numbers were too small.
Wait. I'll repeat. Yeah. So
I just was wondering what's too small. What was the limit for small? Like, what is it set at? Like, what is a small? What's
200,
considered a small sample?
200 in a cell.
200.
Yeah. But maybe what I'll just say is, look, we're the best way to learn about this is to do it. Like, Dan, you've done a lot of it already, so but having we actually have our data now, and the real data sits behind it. Okay. And so what I would just say is there's a process which we're going to build, which will allow ultimately to get to the real data as required. Okay. And as I said at the start, there's not like 8 people for an organization of 15,000. Like today, there's 8 people who are supposed to help 15,000 people get access to data. Now you can get directly in and see. Okay. And so the idea is that we'll get to a process by which you can quickly go back and forth, and you will learn how to deal with the small sample size. Like I know it's possible.
Yeah, I have, maybe stepping back 1 second, I have a more generic question for you. This is a two-way street, obviously, and you're trying to help for the hospital, but also the investigators. I don't know much about it. You mentioned about publications that talk about having used MDClone, but do you know how many peer-reviewed funding agencies would accept this type of data to apply for pilot grant, feasibility grants, hypothesis generating grants? And so
I don't. I can speak to the experience at Intermountain Health in Utah and University of Chicago. They've been tracking the dollars of grants coming in after using MDClone, and it is in the tens of millions of dollars. So I don't know if Canadian is going to equal, but they have been using. Yeah, so maybe in millions of dollars, you divide by 10, but the idea is that yeah. And the other thing is like, let's say you do an analysis. Let's say let's say you're doing GI bleeding. Let's say you're doing an analysis on GI bleeding, and you find there's, I don't know, how many admissions a year for lower GI bleed, this at MUHC. There's, maybe someone could tell me that in their question. Lower GI time to scope, admitted to surgery or admitted to medicine. We could even analyze who gets out faster after adjusting for the amount of blood loss, who gets their scope faster, etc. You know, once you do that analysis and you look at the N, we could say, well, let's look at the real data, like because it started to justify the question, right? So the other, last thing I'll just say is that we're on this journey with some other leading organizations. Like I mentioned, University of Chicago, Intermountain Health, Manchester Trust in the United Kingdom. There's a couple of others in Europe. They're just about to sign, big ones. There's a large health system in South Africa who has a very sophisticated data infrastructure. And all of those people, and Albert Einstein in Brazil, in Sao Paulo. All of these institutions have very sophisticated data infrastructures and want to work collaboratively. So if we have, what's that? And they all have MDClone. So if we want to learn how they're doing it, we can connect you with colleagues in those other places, and we can easily set up multi-center studies. Again, accounting for the small samples. Yeah.
About your question, I don't see a limitation in terms of requesting findings, sample calculation, feasibility, pilot, but to publish something using only synthetic data, there we see some limitations. I see some rejections of articles.
We did one though, but a guy here did publish something as a sole, like the person in neurosurgery. He published a data analysis. Yeah. Okay, let's wrap up. I was told we had to be out of here at 1, and Susan's going to kick me out. And thanks for Susan for organizing and making this all work. Thank you all for coming, and we're available if you have questions after. Thank you.